afternoon. My name is Sidney Watson. I'm a professor at St. Louis University in our Center for Health Law Studies. I think as one of my former students, Ed Martin, mentioned, we have had a Center for Health Law Studies for over 30 years, and for the last 12 years we've been the top-ranked country in the program. So it's a pleasure to be here today. I provide written testimony both for myself and for Professor Tim Graney. He cannot be here today. He's on a plane to California. Professor Graney is an expert in healthcare competition and competition theory, and he submits to you an article that he recently published in the Kansas Journal of Law and Policy about health insurance markets, the problems in the markets, and how health insurance exchanges are a market-based solution, and also his proposals encouraging states to implement their own exchanges rather than defaulting to the federal standards. My area of research is in access to health care, particularly improving private insurance and Medicaid, and I have followed the health reform debate for about 20 years. I too encourage you to implement a health insurance exchange at the state level. One of the things I talk to my students about each year as we study health law and policy is to locate law on a spectrum from regulatory theory to market theory. And health insurance exchanges fall on the market theory side. They are designed to improve the markets, to make the markets for individuals and for small employers more affordable by giving them the economies of scale that exist for large employers like St. Louis University, to make the marketplace more transparent, to make competition work, to bring down the cost of overhead, and it's a good market solution. I also want to point out, I often talk about exchanges as the Expedia of health insurance because that's how most of us will experience it, a web portal where we can compare policies. The name exchanges was coined by the Heritage Foundation when they proposed this new idea a number of years ago, and that's a direct reference to the stock market exchange, which functions much like we want a health insurance exchange to function, to set minimum quality standards so consumers know they're not buying junk, not being flim-flammed, they know what they're getting, to create a one-stop shopping place where people can see all of the options that are available. Policy decision that I hope, as you debate a bill, you will consider leaving that decision to a state exchange function. Massachusetts, when they created their connector, which is the model for an exchange, merged those two markets, and in so doing, created a much bigger market that literally overnight brought down the cost of premiums in the individual market by 23%. A recent study by the state of New York, they also indicated that merging those two markets would very likely bring down the cost in the individual exchange. If we do not move forward on a state-based exchange, we will not have the option to make this decision. We also, I'm out of time.
Yeah, just kind of
I'm done.
All right. Yeah.
I point out some
Hold on a
other
second.
issues in my written testimony. Thank you.
Senator Lager.
Hold on just a second, Dr. Schaaf. I got Senator Lager has a question that says Senator Cunningham, then I'll get to you.
You talked about access. What is your opinion of the FQHCs throughout the state and how they play into everything that's happening here?
Well, federally qualified health clinics or community clinics have been a very successful innovation in increasing access in underserved areas for underserved communities. They are considered in the proposed federal regulations, which would govern the health insurance exchange, to be essential community providers that insurance companies will have to include in their networks. And that won't matter whether we have a state-based exchange or the federal exchange. One of the important issues is what other types of providers will be considered essential community providers. I sit on the Rural Research Health Institute Rural Health Panel. We submitted comments about essential rural providers. I'll be happy to give you a copy of that letter.
And how are those the reimbursement rates or the contractual rates between the FQHCs and the insurance providers? Are those mandated? Who determines that rate? Because right now, in your FQHC setting, their reimbursement is essentially cost plus.
Right, they get cross-based reimbursement, but they are actually moving to a prospective reimbursement method, as will many of our safety net providers, because we provided them cost-based reimbursement because they have covered so many uninsured. So some of those payment mechanisms are in flux. The protections in terms of how they are paid by health insurance companies will not vary, though, depending on whether we have a state level exchange or a federal level exchange.
And the reason I ask that is because when do we start moving away from a cost-based model to a best practices model? I mean, I work for a company that employs about 10,000 people. Approximately, this particular company pays for approximately 300 babies to be delivered every year. There are 2 large hospitals in the area. Both have great quality standards, both do a good job. There's $7,200 per baby difference between hospital A and hospital B. And at some point, we have to understand that it's no longer about cost, it's about best practices and how do you optimize that payment structure. And that's what I'm trying to get my mind around that I haven't been able to do.
Yeah, I agree with you completely on this. The accountable care organizations are one policy directive that will issue this. I'd love to have a longer conversation with you because it really doesn't matter in terms of how we set up the health insurance exchange, how that's going to work.
And the reason I call this in perspective is because we can have a great debate today about having an exchange, not having an exchange. The real reform coming in healthcare is going to be when we start having financial reform and driving to what we're really talking about today, which is cost.
But I will say the analogy is when you talk about the 2 hospitals with very different costs, what the health insurance exchanges bring us to the health insurance market is that transparency of pricing, so that consumers can see which policy gives them best value for the least cost. That's the market theory here. It works at the insurance level. We're also going to have to make it work at the provider services level. Absolutely.
Thank you.
Thank you for talking about what we were requested to talk about, what's the difference between the federal and the state and what you think we should do. You talked about your emphasis on the markets and the free markets as opposed to regulation. Do you not think we have a free market now with the broker system? Comment on the broker system, because do you think that...
Thank you, that was my next point that I didn't get to.
Okay, because you talked about, right now, buying junk and flim-flammed, so,
Well, a broker can only offer what they're given. When I say flim-flam, I think many people are very concerned because we have no requirements, for example, in Missouri that maternity care be covered. My students and I looked at 72 policies in the individual market that are available in St. Louis, and not one of them covers maternity care.
Okay, so we're talking about mandates, though, and it's not free markets, and like the man talked earlier, people wanting to buy just the plans that fit them. I don't need maternity care, I'd rather not pay for it. So,
and that won't matter whether we have a federal exchange or a state exchange. What will make a difference is your question about insurance brokers. In the proposed federal regs for health insurance exchanges and in the Affordable Care Act, it leaves to the exchange operator the decisions what role brokers will pay in the health insurance exchange. Any exchange may allow brokers to participate but does not have to. So if we set up an exchange here in Missouri and authorize the exchange, that exchange will have the ability to decide that insurance brokers will be able to sell policies within the exchange and continue to get broker fees. If the federal government sets up the exchange, we don't know at this point what decision they will make there. I will also say, as part of the Rural Health Panel, we submitted recently comments to the federal government on the continuing role of health insurance brokers, which I would be happy to share with you.
We talked about this at a former hearing with regard to navigators versus brokers.
And they are different functions.
Well, that was in question. John Huff did not know what a navigator was. So at this point, we don't know. Also, whether or not we are free to do it outside of the federal approval is another question too. You mentioned reduction in premiums in Massachusetts of 23%. Is that just a portion of the market? Because our information is the premiums actually went up 40%.
That was a reduction in the individual market. Their premiums in the small group market went up about 0.4%. When they merged the two.
Could you get that information to us, because I've gotten just the opposite. I've gotten an increase in premiums of 40%.
Yes, I can provide you a site to the Journal Health Affairs.
Okay, that would be appreciated. With regard to Utah, what they opened it up to the market, but most that were it became an insurance pool almost. The very sick gravitated to it, and then those others had to be forced to it. That doesn't feel like a free market to me.
Well, the Utah program was never intended as the Massachusetts Connector was to cover a large group of people. It's a relatively small pooling mechanism. So it's very hard to draw lessons from it in terms of what would happen in Missouri if we set up a health insurance exchange that would be available for everyone who uses the individual and the small group market.
Okay, thank you.
And remember, one choice we get to make as a state if we set up our own exchange is how many small employers will be able to use that market. Under the Affordable Care Act, it can initially be opened up to all employers with under 100 employees, but states can limit that in the first 2 years to smaller employers of only under 50 employees.
You had mentioned Heritage Foundation to a proposal. Are you aware that they've turned around now recently?
Yes, I am. It seems that they're more worried about the politics than the policy.
Dr. Shop, are you still on the line?
Yes, I am. I have a question.
Sure, go ahead.
What I think I heard her say was that in the individual market, after the exchange, the premiums came down 23%, but that in the small group market, they actually went up 0.4%. Is that correct?
Yes, they had actually predicted that they would see a cost increase of maybe up to 3 or 4 or 5%, and were quite surprised that that did not occur.
And by what mechanism supposedly did the premiums in the individual market drop by so much? Why did that happen?
It was the increasing of the size of the pool. More people were getting health insurance, and in particular, what happened at the point at which the individual mandate took effect in Massachusetts is they saw a huge uptick in young men, young healthy men getting health insurance by increasing the size of the pool, and including those who use very little medical services in any year. It caused the premiums to go down for the pool as a whole.
Okay, so basically what I'm hearing is that it was the mandate that forced all of the sort of young healthy ones into the pool that drove down the cost in the individual market, right?
Well, we can't separate which of the pieces caused which of the prices in terms of the role of the mandate versus the exchange. We always know that mechanisms that increase the pool and bring in young, healthy people will help us have the lowest prices. We do have an October 26, 2011 report from the Lewin Group, which was just published in Health Affairs, which models how the exchanges would work if we did not have a mandate. Their estimates are that we would cover about 23 million newly insured people, which is about 7.8 million less than their modeling shows, and that the premiums would be about 12% higher without a mandate. So according to their numbers, the mandate saves us about 10% overall.
So if there is no mandate, by whatever mechanism, the Supreme Court, whatever, then if we pool these together, then we could actually expect a pretty significant increase in the costs for the individuals, correct?
No, this modeling is with a mandate, without a mandate. I take your question to be, would pooling the individual and small group market in Missouri reduce the present costs in the individual and small group market? And without doing the economic modeling, I can't be sure. I can say to you, based upon modeling that's been done in other states, simply growing the size of the pool typically brings down the cost, and part of that is simply the administrative costs that are involved in maintaining two pools, two sets of policies, two sets of marketing.
We were sent an actuarial analysis that showed or suggested that if they merged the individual and small group markets, that you would expect a decrease in the individual premiums, but that the small group premiums would rise very significantly.
Well,
and that's assuming that there is no mandate.
Well, and that's always the question. You've got to balance the effect on both markets. We have to see whether employers are going to continue to offer small group insurance as such, or whether they will use wages to encourage their employers to use the individual market once we have a better functioning individual market.
And if we go with the federal exchange, are you saying that we won't be able to make that decision to merge small group and individual? Or are you saying that we will have to do it, or what's the dynamic there?
I don't know that we have a last answer. We won't have as much control as we would if we set up our own health insurance exchange. What I would suggest in terms of authorizing legislation is not making a final decision on whether to merge or not the small group and individual market, because we do need some more empirical data. I would discourage the Senate from passing a bill that prohibited a state-level exchange from making this decision when we have more information.
Thank you, Mr. Chair.
No problem. And also, we'll make sure you get the contact info of this witness in case you have any follow-up questions. So thank you very much. We sincerely appreciate it.